Mr. Chairman, thank you very much for the nice introduction, and I would like to repeat my annual thank you to the LCR and the Lebanese Society for having me third or fourth time this year again. It's a great pleasure to come back. Special thanks to Professor Sarkis and to Fadi putting all together this very interesting meetings. Before going further in my presentation, Fadi selected a nice topic for me regarding the guide wires and how to select them in our daily practice. I would like to share with you some historical moments we are living in my career in Montreal University Hospital Center. I had to work in Hôtel Dieu de Montréal, Hôtel Dieu du Centre Hospitalier de l'Université de Montréal. This is the oldest hospital in Montreal, 372 years of existence. And in November 5th, we moved to a new facility. This is what you are seeing here in Montreal downtown that opened in September 29, and we moved in November 6. This is 300,000 of square meters of constructions, 772 rooms dedicated for patients, 39 ORs, 25th floors building, 65 annual visits to the ER, 65,000 of annual visits to the ER, 10,000 employees, 900 doctors. It's planned to give care to 500,000 of patients per year, 700 university professors, 6,000 of students, and research center with 275 researchers. So it's a historical moment for us in Montreal to move to this new facility. I can tell you that I can walk for 10 to 12 kilometers per day, just going up and down, doing consultation or seeing patients. So the session is dedicated for ABCs of interventional cardiology. And I cannot talk about guide wires without giving a word regarding the guiding catheters. It's a supportive conduit that will help us to advance the guide wires and other devices. This is, of course, the vehicle for contrast injection. We monitor our friendly blood pressure all the way during diagnostic and interventional procedures. The selection of the guiding cutter is a critical moment for the procedure. Before going to the selection of the guide wires, we need to look to the orientation, the takeoff of the vessel, and we need to select atraumatic tip guiding catheters, taking into account that we need support, we need lateral wall apposition depending on the aortic size, and we need guiding catheters that give us a good torque, do not kink, and we can see them on the fluoroscopy. We usually use for the right coronary artery interventions, if they have a simple coaxial right coronary artery takeoff, we use the JR4, that it's the most commonly used guiding catheter. If we need a low or moderate level of support, we can use the deep throating technique. We can go down, or you can use extension catheters if you need higher support. However, when you have a coaxial alignment issue and you need an extra support, then it's better to take other guiding catheters that can sit deep in the sinus of Valsalva, such as the hockey stick. I usually use the left amplatz, either short tip or 0.75 or left amplatz 1. For the left coronary system, extra backup are the most commonly used guiding catheters that will give us a good coaxial alignment with a power support from the opposite size on the aorta, as you can see. Coming back to the guide wires, the objectives that I put for the presentation is to talk about the components of guide wires.
Good afternoon. I want to welcome all of you to this first session of the Lebanese Society of Cardiology meeting. It's a big pleasure to be here, and I want to thank the organizing committee for a wonderful meeting they have programmed for us, especially Professor Antoine Sarkis, the head of the Lebanese Society, and Professor Fadi Abu Jawdi, the head of the interventional committee. So it's a big pleasure to be with you today. Just from reading the program, I see it's a very didactic meeting with hand-on session, lectures, a lot of interaction. So I hope you will enjoy your time and you will learn a lot. I also want to welcome our panelist, Dr. André Aoun from Mount Lebanon Hospital, Dr. Naji Azzi from Hôpital du Levant, Dr. Samah Abu Asi from Hôpital Ain Hussein, and Dr. Mish Fahd from Abu Jawdi Hospital. Our first lecture will be given by Dr. Ziad Dahdouh, a colleague of ours. It's a big pleasure to have him in Lebanon today. Dr. Dahdouh is an interventional cardiologist who has worked in France for a long period of time and has recently joined the King Faisal Hospital in Saudi Arabia. He is going to talk on bifurcation lesions.
So first I want to start by thanking the Lebanese Society of Cardiology for this invitation and sharing a topic in this meeting. The second, I want to pay tribute to my professor, my mentor, Gilles Grolier, who passed away last year. He used to be a friend for the Lebanese Society of Cardiology and very active there. So our talk is, we'll talk about bifurcations, bifurcation lesion, how we define a bifurcation. A bifurcation is defined based on the side branch, a significant side branch. What does it mean, a significant side branch? Is it a reference diameter, more than 2 millimeter, 2.5 millimeter, irrigating a significant myocardium? Actually, a side branch is a branch that we don't want to lose during stenting. We know the coronary artery tree is following a pseudo-fracture design. That means a branch is dividing in a daughter branch. The daughter branches are divided also in other branches until the microcirculation. The idea that we have 2 diameter in a bifurcation is a wrong idea. Actually, we don't have 2 diameter, we have 3 diameter. The main proximal and the distal, the proximal main, which is like the one here, the distal main are not equal sizes, and the side branch is also different sizes. So these diameters are linked together through a complex formula, like which is the Murray law, and Finney simplified this. So we can see that the main proximal main is equal 2/3 the sum of the 2 daughter cells, the 2 daughter branches. Several classifications were used for bifurcation. The most used one is the Medina classification. What is important in Medina classification is to determine which is the main branch and which is the side branch. The flow in the bifurcation is not equal. The velocity or the flow in the middle or in the center of the vessel is higher comparing with the peripheries. And it will get more higher when it reaches a bifurcation. So we have zone of recirculation, what we call low shear stress. And this will explain the distribution of the plaque in a bifurcation. It reproduces exactly what happened naturally when we have a river and we have a high velocity. The plaque accumulation exists at the level of the low shear stress area. So this will explain why the carina is less likely diseased. So mainly the disease is coming from the periphery. The first question, shall we put 1 wire or 2 guide wires? So to answer this question, we have a Korean registry, the COBIS registry, which showed that an occlusion of the side branch is associated with significant death. There is no significant reverse TLR, and the main predictors for side branch occlusions are the side branch lesion length and the diameter of the stenosis at the ostium of the side branch. The mechanism of occlusion of side branch are several, but mainly the carina shift is the main mechanism. We can see here in the IVS study the carina before stenting and after stenting, the shift toward the side branch. So this will dictate the size of the stent, use the stent. If we're going to use a stent diameter according to the proximal branch, we'll have carina shift and we'll have problems sometime to rewire the side branch and to reopen the side branch. However, if we choose to the distal diameter and will optimize with a pot technique, we will have better scaffolding of the side branch and better access to the side branch. So one of the predictors of the side branch recovery is a jade wire in the side branch. So it's easy, it's better always when we need to preserve a side branch to put 2 wires. Second question, should we pre-dilate systematically the side branch? So a Spanish cardiologist, Dr. Pan, studied this, and he did a randomized trial comparing a systematic pre-dilatation of side branch comparing with no pre-dilatation, and he found that the slow flow after pre-dilatation is less. However, there is no difference in troponin or MACE in these 2 groups, and majorly there is no difference in success of rewiring the side branch either we pre-dilate or not, because side branch pre-dilatation can cause dissection and lead to unnecessary stenting. So we should pre-dilate when we have difficult access to the side branch and when we have highly calcified lesion. Let's go now to the techniques, bifurcation techniques. If we want to divide the techniques, we have 1 stent strategy or 2 stent strategy. 1 stent strategy, that means when we want to stent the main branch and accepting the side branch without putting a second stent. So the provisional T-stenting, so we can see this case. This is actually a 53-year-old male who had anterior MI, extensive MI, and low ejection fraction with non-viable anterior wall on MRI. So we choose to treat his coronaries, his circ, since the lateral wall is viable. So here the main vessel is, let's say, this marginal, the big marginal branch from the circ to the marginal, and the side branch is the second marginal. We can call it OM1 and OM2. So the first step, we wire both vessels. We pre-dilate the main vessel, and then a gentle pre-dilatation to the side branch. There is no dissection after pre-dilatation, stenting of the main branch. So now we have a jailed wire, the wire going to OM2. That's why we have to recross toward the OM2 with a third wire or do switching of the wires. And then opening the struts from the main branch toward the side branch with a small balloon, and finalize the procedure with a kissing balloon. And then we can see the result after stenting the main branch and the side branch. There was no dissection on the ostial of the OM2. So it's acceptable result. And we choose for the same patient to do the diagonal branch after 3 months. That's why we checked his bifurcation, and we can see that the stent is perfectly patent and the side branch is also there. If the result is not optimal on the side branch, so here we have to stent. One of the techniques is a T-stenting. T-stenting is mainly when the angle between the main branch and side branch is close to 90 degrees, between 70 and 90 degrees, and you can see that the T-stent can perfectly match the bifurcation. However, if the angle is less than 70 degrees, a small angle, we can expect a lack of coverage of the side branch ostium, which can cause restenosis or sometimes even thrombosis of the stent. A small technical detail for the proximal strut and distal strut. This is a bench test. We can see here if we cross the bifurcation from the main branch toward the side branch using the proximal strut, we can see that the proximal edge of the stand, the proximal segment of the stand after kissing balloon is distorted. However, if we cross it from the distal strut, we can see that we have circular geometry on the proximal segment and better scaffolding of the side branch. So it's always advised to cross, if it is possible, through the distal strut. And this is also a demonstration by OCT. We can see the side branch compromise if we are going through the proximal stand proximal strut comparing to the distal strut. Still in the one stand technique, the POT, proximal optimization technique, it consists of putting a balloon in the proximal segment of the branch, having its distal edge at the level of the bifurcation. It should be an oversized balloon, and we inflate with high pressure toward the side branch. So it facilitates the rewiring of the side branch, and it also improve the position of the struts in the proximal edge. So this pot is trending with some groups, like the group of Gérard Finet. He studied this technique, pot technique, and he compared it to several possibilities with kissing balloon inflation. So kissing balloon inflation compared to pot with kissing, and then another pot, which he called repot technique, and he can find that if we compare kissing with pot side repot, also will have better position and circular geometry of the proximal part of the main branch and less side branch obstruction. So this is an example for pot side repot. This is an elderly octogenarian who had left main disease. He has also multiple stenting on the LAD and left circ. So he had also tight lesion and a significant on the distal left main. So we choose to go for one stent toward the circ, since the lesion is involving the ostial circ. So the stent is deflated from the left main to the circ. And now we have a jailed wire on the circ, on the LAD. So we recross the struts of the stent toward the LAD, and we pull back the other wire. And then we open the strut. This is side branch inflation, and we do pot with an oversized balloon with high pressure in the left main. And we can see the result after one stent is acceptable on the left main and on the ostial circ and even ostial LAD. Now, if we go to two-stent strategy, the crash technique. So it consists of putting two stents, one stent in the main branch and a second one in the side branch, being protruded largely on the main branch. The proximal edge of the side branch is protruding in the main branch. First, we will inflate the side branch stent. We deployed the side branch stent, and then we deployed the main branch, and then we recross a wire through the struts toward the side branch, and we finalize by kissing technique. This crash technique is abandoned in general, and we are using mainly mini crash technique. So we have minimal side branch protrusion on the left main. The problem with the crash technique, first, it needs at least 7 French guiding catheters, since we are putting 2 stents at the same time, and we have areas of malapposition, and also we have areas of excess of metal, especially in the proximal in the proximal part of the side branch. So we have 3 layers of stent. This is a case of mini crash technique. Actually, this case was done in the north of the kingdom, and we saw this case after several months. This patient, she had multiple stenting on the LAD and circ, and also she had a lesion on the left main going to the circ and to the LAD. So the operator chose to do a mini crash. So this is a 7 French guiding catheter. He introduced 2 stents at the same time. one on the side branch, one on the circ, one on the LAD, and he inflated the stent, the circ stent first. He pulled back the catheter and then inflate the second stent, which is in the LAD. You can see here the inflation. And this is the result after stenting. Definitely here he recrossed the wire from the left main toward the circ and insert two balloons, high pressure balloon and low with a kissing balloon. And this is the result after kissing balloon of this mini crash technique. So I saw this patient actually in our hospital after something like 8 months for recurrent angina. And we did for her coronary angiogram, and it showed tight instant restenosis, mainly starting at the level of the circ, ostial circ. So we sent for this patient for surgery, for CABG. A variant for the kissing for the mini crash technique, the double kissing crash technique, it's actually the same, but it adds one step after the inflation, after the deployment of the stent, the side branch stent. We perform a kissing balloon before the deployment of the second stent. Actually, it seems that this technique is associated with less TLR, but there is no change in mortality as expected. And this less TLR is mainly driven by less instant restenosis and the side branch with double kissing crash, comparing with a provisional stenting with two stents, with the other techniques. The other technique for two stent, the culotte technique. This is a patient. Actually, this one is a recent case. We can see that this lady, she had a tight lesion on the marginal, ostial marginal, and on the mid-circ, and also she had another lesion on the distal segment of the circ, which was stented easily with one stent. And then we choose for this to do a culotte technique. I choose culotte actually because there is a similarity in the diameter of the two daughter branches. So we cross the wire through the marginal, and then we pre-dilate the circ toward the marginal, and then we position the stent. We deploy the stent. So at this level, we have the wire and the main circ is jailed under the stent. So here we have to take a third wire, or we can do switching, but it's always better to take a third wire and recross the struts or the stent toward the circ. What happened? Technical problem. It's okay. It's okay. This one. Go again. Okay, thank you. So again, we recross with a third wire toward the circ. We pre-dilate. We open the struts with a balloon. We can see here the balloon toward inside the struts. And then we advance a stent. It was a little bit tricky to advance a stent for several reasons. One of the reasons, the calcified plaque, the calcified segment and the proximal left circ. However, we managed to advance the stent toward in the circ, keeping the proximal edge of the stent, the proximal part of the stent, inside the previous stent, forming the culotte, like this. And then we inflate the stent. And after inflation of the stent, we can see now the wire toward the marginal is jailed under the new stent. So again, we have to recross with a third wire. We can see here recrossing of the stent, of the wire toward the marginal. This is a second recrossing. Opening the strut, we retrieve definitely the jailed wire, and we open the struts with a balloon, and then we finalize with a kissing balloon. All of this in 6 French guiding catheter. And this is the final result for the culotte technique on this bifurcation. The advantage of this technique is that we have optimal coverage of the ostia, both ostia of the side of the daughter branches. However, we have excess of metal in the proximal segment. You can imagine that we have double layer of struts in the proximal segment. After the culotte technique, the tab technique, which is let's say a recently already new technique. So the T and the protrusion, it is like T technique, however with intentional minimal protrusion of the side branch within the main vessel. And this will lead to the formation of what we call neocarina. So technically, this is the tab technique. This is, again, a circ. This patient came with acute coronary syndrome, and we can see that he had a tight lesion on the distal part of the circ. However, he had disease the whole segment from mid to distal circ, and the marginal also, which is a significant marginal, is also involved by the plaque. So we predilate, and we can see that actually the vessel is not negligible at all. So we stent across the marginal, the first marginal, long stenting. Now we have a jade wire. We have also some pinching on the marginal. However, it was not very difficult to recross the wire. We predilate, we open the ostium of the side branch. And this is the major step for TAP technique. So we have to park a stent. We put
patient for surgery. This is a case of hydrophilic wire perforation, right coronary artery occlusion that was treated, and the hydrophilic wires were not changed to workhorse. And you can see the distal perforation in small branches from the PTAs that were created, and there is 2 of them. So of course we can coil the PDA, but the patient may carry a risk of infarction. We cannot put coil in such a tiny branches. You can reverse heparin, but the patient may continue bleeding within minutes before the effect of stop bleeding by the protomin, carrying the risk of thrombotic event in the right coronary artery. So how to treat here? You take a microcatheter. We use the Renegade microcatheter, and you go on a workhorse at the origin of each side branch, and we use the gel foam. The gel foam, it's a spongy material that you can cut it yourself. You put it on a distal tip of your 3 cc syringe with dye, and you push it by yourself. It will go at the origin of that branch and occlude it. And the gel foam is a bioresorbable material. It will disappear by itself within a couple of weeks. And this is the final results after we occluded the middle part of each side branch. You can see the dye staining there, and there is no more leak to the pericardium, and the patient had a very mild pericardial effusion, no need to perform a myocardial tap, and did not carry the risk of tamponade. So to conclude, 4 points: simplify the list of your wires, take the wires that you are comfortable to use, know the properties and the feels mainly of each wire. Experience is key to feel, and don't take shortcuts. If you are doing a complex procedure, proceed by step. Thank you very much for your attention.